Hello, my name is James Yu, PGY3 in internal medicine at JFK Hospital, and I'm here to present sepsis-induced euglycemic DKA in a type 2 diabetic. Diabetic ketoacidosis is a metabolic acidosis that occurs due to the presence of ketone bodies. It is driven by an imbalance in the ketone suppressing hormone insulin and the basket of ketone promoting hormones, including the catecholamines such as epinephrine, steroids, both exogenous and endogenous, and glucagon. Classically, this occurs in type 1 diabetics due to the complete absence of insulin following the autoimmune destruction of the pancreatic beta cells. However, the condition can occur in type 2 diabetics, usually in the presence of glucosiuria, where the loss of glucose in the urine prevents the endogenous insulin response from occurring at sufficient levels to prevent ketogenesis. So this classically occurs due to the presence of an SGLT2 inhibitors, a class of medications that inhibit glucose reabsorption in the proximal tubule of the kidney. However, theoretically, the condition could be induced by any cause of glucosiuria, and we present such a case here. We had an 82-year-old woman who presented to the emergency department for abdominal pain and nausea. On her initial exam, the abdominal pain was non-localizing. She was diffusely tender. She had a negative Murphy's sign. On auscultation of the lungs, there was diffuse wheezing noted, which was consistent with her. She was a lifelong smoker with a prior diagnosis of COPD. Imaging of the abdomen in the emergency department showed gallstones. However, there was not signs of gallbladder inflammation, so the initial diagnosis was symptomatic cholelithiasis, and the patient was admitted for further evaluation. Shortly after admission, however, the patient went into respiratory distress, was found to be an acute respiratory failure, and the patient was intubated and transferred to the ICU. The patient underwent bronchoscopy, which showed significant mucus secretions causing atelectasis. The secretions were successfully cleared on bronchoscopy, allowing the patient to be extubated. The patient was extubated to BiPAP as she was still having some respiratory distress. And the patient had poor oral intake at this time due to the BiPAP mask, as well as still having nausea. Her bronchoscopy cultures were positive for Klebsiella, so she was started on a steroid regimen for a COPD exacerbation, as well as antibiotics. And shortly, within the next couple of days after this, the patient was noted to have an increasing anion gap, peaking at 24.5. This was further worked up. Her lactic acid was within normal range. However, a urinalysis showed that she had profound glucosiuria with over 1,000 units, and she was also positive for ketones in the urine as well as protein, indicating some possible generalized proximal tubule dysfunction, which was attributed to her sepsis. ABG showed that she was hypoxemic and hypocapnic as well, and it was assessed that she was having a concomitant respiratory alkalosis due to hypoxemia related to her other respiratory issues, including the pneumonia. So she was started on an insulin infusion, which closed her anion gap over the next 14 hours. She was started on insulin sliding scale as well as long-acting insulin, and she was started on a diet as well. So, lessons from this case highlight the importance of taking an algorithmic approach to acid-base disorders, taking a wide differential and considering all causes. And another important takeaway is that sepsis can cause kidney dysfunction, possibly leading to glucosiuria and the possible emergence of DKA, which may be an under-recognized diagnosis in type 2 diabetics in the ICU, given the frequency of steroid use for an increasing number of conditions with stress dose steroids. So thank you so much.